Just going to take some seats and we move on with the program. We have also with the pressure, and now on we're going to be diving into the more advanced treatments for fibrillation, mainly the catheterization, and then later on, we just actually going to be talking about cerebral artery. Hello again. Hopefully you guys had a nice break. No one has fallen asleep yet. So next up today, the next topic will be about catheter ablation of atrial fibrillation. So we're going to go back to our patient, Benjamin Harrison. So he comes back, again, just to remind you, he has a history of atrial fibrillation, hypertension. He's tried antiarrhythmic therapy with flecainide. Did well for a short time, but his AFib is back. And he underwent a cardioversion. He comes to a clinic asking, what's next? Is it time for an atrial fibrillation ablation? Again, we go back to the shared decision-making process. We work as a team. We make care decisions as a team. That's at the heart of atrial fibrillation. And we want to define his clear goals for treatment. And we want to align our treatment with what works best for the patient, what matters to them. So when does evaluation become appropriate with an electrophysiologist? It's important to think earlier, not later. And typically our patients are referred when there's symptomatic atrial fibrillation despite antiarrhythmic therapy, recurrent atrial fibrillation after cardiac, with that medication intolerance or side effects. The patient prefers a non-drug strategy, especially if they develop atrial fibrillation related to heart failure or cardiomyopathy. Those are typically when patients are referred. But it's important to know that even before they get to that, it's important to establish care with an electrophysiologist where we can start the process of discussing what could happen next. So the key shift in modern day practice is EP referral is not a last resort. I believe earlier the referral is made, the better that we can tackle the disease and prevent progression and better outcomes for the patients. Guidelines do support ablation once drugs fail or not. So how does atrial fibrillation really work? And we have to remember mechanisms behind atrial fibrillation. So the pulmonary veins, which feed into the left atrium, which I showed you earlier, I'll show you in the next slides. There are certain triggers that trigger the atrial fibrillation, like the spark. Those trigger and initiate the atrial fibrillation. And then the atrium itself, that chamber in the heart, will maintain the atrial fibrillation, has the capacity. There's an atrial substrate. If the atrial substrate develops, it can maintain the atrial fibrillation. So ablation, what it does is target the elimination of the triggers and the elimination of the substrate. So our goal initially, what we always try to do is isolation, we call it isolation of the pulmonary veins. We try to remove the spark. So an ablation does that. So by removing that spark, we're preventing atrial fibrillation from occurring. But before we move forward with an ablation, we have to always take a step back. We always have to ask, are your symptoms truly related to atrial fibrillation? We want to make sure we're not missing any other diagnoses which could be contributing to the symptoms. Always periodically, at every visit, we want to reevaluate the stroke risk. Is it stroke risk worsening? Do we have to adjust therapies? We always make sure are the rates adequately controlled? We always assess, are the antiarrhythmics working? Are they tolerating the antiarrhythmics? So the patient's actually taking the antiarrhythmics that's prescribed. And it's really, really important to always focus on lifestyle factors. weight, sleep apnea, alcohol, blood pressure. I can't stress this enough, but you must optimize the substrate before or alongside any advanced therapy. So we don't treat the substrate, no matter what we do, no matter what relations we do, we will have a recurring cycle of atrial fibrillation. So sleep apnea, especially treating sleep apnea and weight, they can dramatically impact the recurrence of atrial fibrillation. Who is a candidate for atrial fibrillation? Patients with symptomatic atrial fibrillation, whether it's paroxysmal or persistent. Those who failed or are intolerant to antiarrhythmic drugs. Patients who prefer a non-pharmacological therapy for their atrial fibrillation treatment, which is very reasonable. And especially in atrial fibrillation, patients who have heart failure, especially those whose heart failure is caused by atrial fibrillation. Those are ideal candidates for atrial fibrillation ablation. And we must ask ourselves, why do we do catheter ablation of atrial fibrillation? The strongest evidence is the quality of life. There's trials, the key trials, there's several trials called Havana, which have shown a consistent, robust benefit when patients quality of life. There's a significant improvement in patient symptoms, improvement in palpitations, their fatigue, the shortness of breath. Their exercise capacity often improves. Functional status. So I've seen this personally, some recommendations. Atrial fibrillation ablation is more superior to antiarrhythmics when improving quality. Also, catheter ablation has been shown to reduce the amount of atrial fibrillation burden, the amount of atrial fibrillation it has. Also reduces hospitalization. Strong evidence for this. And this is evidence from well-designed trials, the Havana trial, the Fire and Ice trial. There are fewer AFib recurrences after catheter ablation, fewer ER visits, fewer cardiac admissions, fewer atrial fibrillation-related hospitalizations. Heart failure outcomes. There's a very strong benefit in patients, especially with heart failure. Patients who have heart failure, often with atrial fibrillation ablation, they can have an improvement in the heart function. So you can witness their heart function in patients who have atrial fibrillation go from, let's say, 15 to 20%. They can drastically improve to 40, 45% and normalize their normal heart function. Their functional capacity improves, and heart failure symptoms improve. It also reduces the number of heart failure hospitalizations. And the big thing is there is a decrease in overall mortality in patients who have atrial fibrillation and heart failure who undergo an atrial fibrillation ablation. There's a decrease in heart failure hospitalization. All of this we know from that big landmark study, Catheter. So also, overall mortality in patients even without heart failure, there's some modest but meaningful mortality improvement in some selected patients. Stroke reduction is another big thing. Although there's no definitive independent reduction has been proven that with catheter ablation that there's a decrease in stroke risk, but indirectly, ablation reduces atrial fibrillation burden. So theoretically, that lowers stroke risk. But at the same time, the anticoagulation decision still remains based on the overall stroke risk based on the CHADS score. And I just wanted to address this. Ablation is not a substitute for anticoagulation. It's still treating stroke risk independent whether they had an ablation or not. There are some newer trials which are showing in patients who are at low risk after a catheter ablation, if we can prove that there was no recurrence of atrial fibrillation, you can have a patient-to-physician discussion about continuing anticoagulation or not. But for now, ablation is not a substitute for anticoagulation, and we make our anticoagulation decision still based on the overall stroke risk of the patient. When it comes to dementia, there's some observational studies which suggest that after an ablation, there may be some lower dementia risk, but we don't have definitive randomized data yet. It's believed that we are seeing a benefit, maybe because of reduced overall AFib burden, which results in improved cerebral perfusion and less microembolization. It's promising, but still we don't have any strong data to support that yet. Mitral valve disease is another big thing. With atrial fibrillation, what often happens is there's remodeling over time, and the atria become dilated. And so there's a mitral valve which prevents backflow of blood from the ventricle into the atrium. With atrial dilatation, the valves are stretched and it tries to close, but there's leaky valves develop when the atria become larger. And with atrial fibrillation, and that entity is called atrial functional mitral regurgitation. And with correcting the atrial fibrillation of ablation, the goal is to try to reverse the dilatation, improve the atria kind of hopefully shrinks, and the valves can now optimally close again, prevent the backflow of blood, and that can help with mitral valve regurgitation. So there's multiple studies showing an improvement in functional mitral regurgitation after atrial fibrillation ablation. Now, this is different from actual valvular pathology, valvular disease. That's different, where the actual valve has to be corrected, fixed or repaired. Probably was not sure it does. This is slightly different from that. So let me talk a little bit about anatomy here. So this is the heart, it's sliced in half, and this is your right atrium, your right ventricle. This is your left ventricle, your left atrium. So blood flows from these big veins, the superior vena cava, inferior vena cava. Blood enters this right atrial stream, then it goes into this right ventricular stream. And the blood flows out through these pulmonary arteries, and they go to the lungs, they get oxygenated, and then they come back through these pulmonary veins. There's these 4 veins that feed into the back of the heart, the left atrium. They go here, the blood then travels down to the ventricle, and then it's pumped out to the aorta to the rest of the body. And this is just a view of the heart from the back. This whole structure here is the left atrium. You have the pulmonary veins, which are feeding into the heart. And it's in the endocardial surface, the inside of the heart, the triggers, where the pulmonary veins are feeding into the heart, where the triggers fire into the chamber, causing the irregular heart rhythm. So there's a cartoon figure. These are the pulmonary veins feeding into the left atrium. And these are the triggers that fire, the spark, that results in the initiation of atrial fibrillation. And so our goal during catheter ablation is we want to block these triggers, prevent these triggers from entering the heart itself. And so we do a procedure called isolation of the pulmonary veins. We encircle these veins. We encircle them so that the signals cannot enter the heart. So we create a line of ablation, isolate the veins. How do we do an atrial fibrillation ablation procedure logistically? So we do this most often under general anesthesia. Although some centers are trialing to do this on conscious sedation, but mostly under general anesthesia. Oftentimes, we do a transesophageal echocardiogram. That's a small camera that we put in the mouth down the esophagus. And we're taking pictures at the back of the heart. We want to make sure that the patient does not have any blood clots prior to proceeding. Sometimes we do find blood clots, and then we have to take the patient off the table, wait until the blood clot dissolves, and then back again. But once we make sure that there's no blood clot, another thing we do is we put a temperature probe in the esophagus. And we do these procedures with minimal X-ray use or no X-ray use. The total procedure time lasts about 2 to 3 hours. Following the procedure, there's bed rest for about 1 to 2 hours. So the patient can usually walk out of the hospital in 3 hours or ambulate in 3 hours. Following the procedure, you might have some mild discomfort, some chest discomfort, some mild groin discomfort. Patients are oftentimes, they go home the same day. So it's the same day procedure. After a 4 to 6 hour observation, they go home and they often resume normal activity in days. This is a typical our lab at University of Cincinnati. Right here is our EP table. This is where the patient will be brought into. These are our nurses and techs who are helping up set up the table prior to the procedure, prior to the patient coming in. We have all this equipment, we have these large screens. So the patient's rolled into this table and we have the patient lying here. This is where the anesthesia team works. The first thing, and this is a close-up view of the table, all this equipment, every one has a function that we use to help care of our patient. This is the table that the patient lies down on. So the first thing that we do when the patient comes in is we place these patches on the front and back of the chest. And what these do is these help localize the catheter while it's inside the body. The catheter, it works on magnetic principle. They triangulate where the catheter is in the body at all times. So we're able to visualize the catheter in these mapping systems. And I'll show you some examples of that. And this magnet right here kind of sits under the table, and then we have these patches. So as the catheter moves in the body, we're able to track it on this mapping system. It kind of works like a GPS system. So the patient comes into the lab, we put these patches on, and then the patient lies down. Here's the anesthesiologist who has already intubated the patient. And you have a physician working, a nurse working at the table, helping with the procedure. We have some of our things that we do here. And then we have these screens, so we're able to visualize at all times what we're seeing. We have different EKG readings, so we're always monitoring the patient. And here's the X-ray machine in the back. We don't always use it. Very rarely we do sometimes use it. If we need it, we pull it back in to here. So the first thing that we do is after patients intubated, we have the patches in place, everything's prepped, they're sterilized. There's a vein that goes, it's called a femoral vein that leads all the way up into the heart. We put the little IVs in these veins and we take up these catheters all the way up into the heart through these little veins. So there's like tiny punctures that we put in the veins. We typically do 3 of those in the same vein, and we take up 3 different types of catheters up into the heart. This is an example of an X-ray, and this is the heart. So one of the catheters is called a NICE catheter, or an ultrasound catheter. This right here, the small catheter here. That gives us ultrasound images of inside the heart, so we're able to visualize what's happening inside the heart. Then we have another catheter, which is just a recording catheter. It records all the electrical signals of the heart, which we place in a certain position in the heart, and it picks up on here. You can see the signals of the heart, and so we're always monitoring the signals of the heart. And then this is the actual ablation catheter that goes into the heart, and we use this to go to different. We map the heart and use a procedure called mapping, and we also use it to ablate the heart. So there's different types of ablations. One of the so when we get to the heart, no matter what type of ablation strategy we use, we go through that big vein, and we always cross over into. So we're going into the right atrium, right? There's a wall connected between the right atrium and left atrium. We do a small puncture through the left and right atrium, and that allows us to feed our ablation catheter into the left atrium where we have the target. And there's different modalities of ablation. One of the modalities is called cryoablation, or we freeze the tissue. So by freezing the tissue, we cause cell death around the veins. And so we have to freeze the tissue to a minus 30, 40 degrees. That causes irreversible cell death. This is a technology which has kind of fallen out of favor. This is really not used much anymore. What has taken over is this technology called radio frequency ablation. And there's another technology I'll also talk about as well. So this is kind of like heating the tissue. So it sends radio frequency energy, which heats the tissue, causing cell death. So here we are doing little, sending little heat energy in certain areas, point by point, around each of the veins to cause cell death in those areas. And it prevents the signals from the pulmonary veins from entering the left atrium. So there's cooling, freezing technology, which has again fallen out of favor. Very, very rarely it's used, not so much used for atrial fibrillation, and maybe used for other things. And there's heating the tissue, which is radio frequency energy, which causes cell death. This is an ultrasound image right here. This is the right atrium. You can see some of it, and this is the left atrium. Here we're using a tiny needle to cross over into the left side. We create a little puncture, and this space allows for the catheters to go into the left side of the heart. Again, it's a very small hole, and within 3 months, it seals up by itself. So it's not a permanent hole. It's a very tiny hole which automatically seals up. This is one of our, it's a team effort, and this is one of our mappers. They are mapping, while we're moving the catheters inside the heart, they're helping us navigate where the catheters are and helping select different sites of ablation. So we're creating an image using this magnetic technology, using the catheters around the left atrium, create this image, and help find the actual place where we'd like to ablate. Again, we take our catheter to the left side of the atrium, and we use either freezing or radio frequency energy. This is a close-up of a freezing technique. This is the vein right here, and we take this balloon here, and then we freeze this tissue wherever it comes in contact with the balloon, and freezes it, causing irreversible cell death. There's this new technology that's at first was being studied in about 2018. And about 2025, it's been mainstream. It's called pulse field ablation. So we talked about freezing the tissue. We talked about heating the tissue. This is called pulse field ablation. What this does is it sends electrical impulses. And these electrical impulses puncture the individual cells. They create pores in the cells. This is a process called electroporation. It creates pores in the cells. And this causes influx of certain ions, efflux of certain ions. And then ultimately, the end result is cellular death, necrosis. So this is another modality which is now taking over and may one day become mainstream and may completely take over the radio frequency energy. So this is what we here offer at UC, and it's also being offered at other cases now, but this is the latest technology that we have, called pulse field ablation, and we have such promising results from this so far. Again, these are electrical impulses, and what is nice about this is that you can select the energy value of this electrical impulses, so it selectively targets certain tissue and it doesn't target other tissue. With radio frequency or with cryoablation, we always worry about collateral damage. If we're heating the tissue, it's going to heat everything in its way. So if there's other structures like the esophagus, which you don't want to be damaged, it can unfortunately heat that too. Whereas the pulse field ablation, the risk of collateral damage is less, because you can select the energy delivery to target the atrial tissue specific. There's different types of catheters that are used. This is what we most commonly use, the Varipulse, but there's also FARAWAVE, Sphereline, pulse lines. Different catheters which deliver the electrical impulses into the heart. This is a map of, so this is just, this whole thing is the left. This red here is the pulmonary veins. So initially we mapped out these areas. We created a nice geometric shell using the mapping system. And what we did, these lesions are the electrical impulses that we delivered. So we delivered them around the veins, and these prevent the signals from the pulmonary veins entering the actual heart. And so it kind of creates alignment blockade. Here's another example. I put this example in here to show you, this is a tracing of the esophagus. The esophagus sits right behind the left atrium. So this is nicely positioned in the center, but sometimes we have the esophagus laid right over here. And unfortunately, that's where we need to ablate. So we have to be mindful of and careful of any esophageal damage. And we use a temperature probe, always monitoring the temperature of the esophagus. And there's a huge alarm that goes off if we cross a certain point. And so this is just to show you the proximity of the esophagus with the atrium. Sometimes we have to do more than just pulmonary vein isolation. As I told you, there is an atrial, in more advanced conditions, the atrial substrate, the atrial goes remodeling, and the posterior wall can become a area that can initiate and can also maintain the atrial fibrillation. Sometimes in more advanced conditions, we have to ablate the posterior wall of the atrium itself. And so this is just an example where we went in and we ablated not only around the pulmonary veins, but the entire posterior wall as well. So the procedure takes about, I tell them 2 to 3 hours, but some of our physicians it depends on each person's anatomy. Some patients, they go faster than others. Sometimes we're done in an hour. But then at the end of the case, we take out all the catheters, and what remains is a tiny holes, tiny punctures in the skin, in the groin area. And then what we do is we use an instrument here, and we deliver some collagen, which seals up that area. And most of the time, there's no bleeding afterwards, but there's a small chance that this collagen can sometimes move a little, and that's why bed rest in the first hour is critical, or it may not stay in one place, and sometimes there's one of the complications we do have, which is a minor complication, some oozing at the site of puncture. What can a patient expect after an ablation procedure? What does success look like? So paroxysmal atrial fibrillation, the success rate that I tell my patients, 70 to 80% with a single procedure. Nowadays, we're seeing 80 to 90% as well. Unfortunately, there's a 20 to 30% chance of recurrence of atrial fibrillation in our paroxysmal AFib ablation patients. Oftentimes, that may require a little touch-up. The areas that we ablated, remember there's one, when we send electrical impulses or radio frequency energy, there's irreversible cell death and there's just regular reversible cell. So areas which we ablated may have been damaged and not irreversibly destroyed, and unfortunately they can recover it and they can start allowing for the firing of the signals. And so we have to keep in mind that that can happen, or it could be just a general progression of the condition and other areas. You can have non-pulmonary vein triggers, other areas of the heart can start triggering the atrial fibrillation. That's one of the reasons why we have recurrence as well. And so this is one of the reasons we don't immediately take patients off of anticoagulation, because if this was 100% successful, maybe there may be a role in taking patients off of anticoagulation, but still we don't have a modality that tells us this is going to be 100% successful. And as the disease progresses and it becomes more advanced, unfortunately with persistent atrial fibrillation, the success rate is much lower. The rate that I quote, success rate is 60-65%. They often require repeat procedures. They may end up requiring other procedures that our Dr. Sebastian will talk about in this spot. That's why we tell our patients that in general, the earlier that we tackle this condition, the better outcomes. And so as after an ablation, it's recurrence may happen. It doesn't mean it's a failure. It's still part of the disease process. When you have atrial fibrillation occurring within the first 3 months, that can happen. It doesn't mean that the ablation didn't work. Within the first 3 months, it's called a lagging period. After an ablation, there's some inflammation. It takes some time for the inflammation to resolve and not be the source of the AFib. So usually after 3 months is when we'll have a general idea of how the ablation goes. For any patient that has an AFib ablation, we continue anticoagulation for 3 months regardless. And the long-term decision, we base it on their stroke risk. But just to clear up an important misconception, and patients ask me all the time, can I get my ablation and stop my anticoagulation automatically? The answer is no. There's a lot of factors that go into it. So we don't do an ablation for stopping anticoagulation. We do it to try to fix the disease process itself. What are some of the complications that can occur? You can have vascular complications. There can be bleeding or hematoma of the groin. We use ultrasound, and we definitely decrease any complications much lower than what was previously reported. There can be cardiac complications such as a tamponade or a fusion. So it's tiny because of the inflammation during ablation. You can have fluid buildup or tiny micro punctures in the myocardium, which there can be fluid buildup around the heart, the lining around the heart. If that were to happen, we would, drain it immediately. Usually, it's not a problem. The chances of this happening are very rare, 0.4% of the time. Most of the time, 99.99% of the time, they're able to drain it. Patient does well, and that's the strokes. Unfortunately, are a procedural complication which can happen. It's 0.15 to 1% of the time. There's pulmonary vein stenosis. The vein itself, it can shrink. I tell my patients it's like kind of like those shrink wraps. If you heat up the shrink wrap, it like shrinks the material of the book or something. So the vein, if you're heating the vein, it can shrink the vein a little bit, but we're careful to go away from the vein and not ablate too much inside of it. And that's one of the advantages with the newer technology. It's less pulmonary. The phrenic nerve, which is helpful for breathing, it moves your diaphragm. Sometimes that's in the vicinity of the catheter where you need a vein that can undergo also damage to the phrenic nerve. But again, we're always monitoring. And again, highly likely to happen, especially with all the newer technologies, newer modalities. And the biggest fear is what we call atrial esophageal fistula. It's very, very rare. And that's when the esophagus heats up and damages our esophagus. But again, this is highly unlikely. We have a temperature probe in at all times, and we're always monitoring temperature. So when the tissue starts heating up, we immediately turn off the ablation. We wait for it to cool down. It's something we haven't seen here, but we see. With the newer technologies, these complications are much less, especially with pulmonary vein stenosis and treatment. With PFA, again, comes other complications we didn't realize we were having with the technology. Sometimes brings in newer complications. You can have coronary spasm. Again, is rare. Sometimes transient phrenic nerve paralysis, which is again rare. But overall, pulse field ablation has shown to improve or decrease the risk of complications. And so in the modern era, any complication about 2 to 4% chance of happening, major complications 0.7% to 2%. That, I mean, it's reported, but I mean, this is super rare. We haven't seen what we haven't seen. And even in our centers, high volume centers, major complications are way less than 1%. So complications can happen with any procedure, but the risk of the complication overall, I would say less than 1%. The big takeaway is earlier the ablation, especially when it's in the process of stage, the higher the success, fewer procedures, better durability. And the take-home point is catheter ablation is a guideline-supported therapy for symptomatic AFib. It's not a niche therapy, it's mainstream. The best candidates are symptomatic, drug-refractory, drug-intolerant patients. The goal is to reduce AFib, improve quality of life. Success is high, but it's not absolute. Shared decision-making is a part of atrial fibrillation. Atrial fibrillation is progressive, timing matters. Earlier intervention, better the outcomes. Delay and intervention is more remodeling, lower success. So those are some of my take-homes. And unfortunately, not every ablation every AFib we can tackle endocardially, meaning inside the heart. There is a role for what we call epicardial ablation, and that is where my friend and a colleague, Dr. Spinaccio, will be talking more about. There are connections. So we, as electrophysiologists, we can ablate inside the heart, but sometimes there are connections or areas that we cannot reach from inside the heart that we may need techniques to do outside of the heart, to ablate on the outside. So those are some of the things that Dr. Spinaccio will further touch on. And before I end, this is just want to stress, this is a team effort. There's multiple people involved: the primary care physician, general cardiologist, the electrophysiologist. We always have surgeons that's back there that we discuss cases with. And then most importantly, people who don't get credit, I'd like to mention our scheduler is Lisa here. I would like her to stand up for me if she's here still. Lisa's the one that she helps schedule patients. Stephanie Bird is our AFib coordinator. She is responsible for helping put this program together as well. Courtney, Shayla, and Bridget are all nurses in our EP lab. who are there helping take care of our patients, and they help make sure we're not make sure we're doing our job, make sure we're not missing anything. They're laying eyes on the patient and providing comprehensive care to the patient. So thank you guys for your time.